Good evening, good evening, my professors and colleagues. Okay. Good evening, my professors and colleagues. I am Mohamed Sanhoury from the Cardiology Department at Alexandria University. It is my honor to have working with me Professor Shibo Matteo from Hamburg. I'll start to introducing our team. Shayma, nurses. Dr. Ahmed Mukhtar, Dr. Mu'taz Zaki, Mr. Ahmed Abdel Moula, our technician. Mu'min from Medtronic, Ahmed, nurses. From anesthesia, Dr. Karim Ateba, and Osama, nurse. Today we have a male patient with paroxysmal atrial fibrillation, highly refractory to medical treatment. I'll give short resume on the case. Please, the case. He is a 25-year-old male patient. He is not diabetic, not hypertensive. His body mass index is 29 kilogram per square meter body surface area. He is complaining of highly recurrent atrial fibrillation, refractory to medical treatment. He tried sotalol, flecainide. He received, by the way, 2 DC shocks in the previous 2 years. His echocardiography is completely free, with left atrium diameter is about 38 millimeter. Next, the Schatz-Vask, next please. The Schatz-Vask score of the patient is 0. I leave now Dr. Shibo Matteo to tell you what we did so far. Please.
Yeah, so also from my side, a warm welcome from the EP lab here in Alexandria. We prepared a pretty nice cryo case for you. And if it is okay for you, we would start immediately. We would show everything what we done so far. Okay. I think you should go to your places. Okay, can you show us the first angio we did? Go back. Okay, stay here. Okay, so as you can see, what we did so far is, initially we punctured 3 venous groins. We had 1 catheter in the coronary sinus. We put it in a very distal position and performed a transeptal puncture. It looks a bit high at this position, but I think the transeptal side is okay. We gave some contrast, and in the next step we changed the transeptal sheath to the cryo sheath and performed for you selective pulmonary vein angios. Maybe we can show the pulmonary vein angio. Show the first angio. So this is the right superior vein in RAO 30. We can see the next angio. This is the right inferior vein, also in RAO 30. Very important from our side, we have the table fixed. We don't move anymore the table. We use only 2 standard projections, RAO 30 and LAO 40. So everything is reproducible and very easy at the end of the day. From this anatomy, the right inferior vein is not too small. It can be a bit challenging, we'll see. And show us the next angio, please. This is the left superior vein in RAO 30. The next, please. This is the same vein in LAO 40. As I said, we use our standard projections. And the next is the left inferior vein. Please show the next vein. This is, and one more, this is the mid branch. The next, please. And here we can see nicely the very inferior branch of the left inferior pulmonary vein. And this will be also the target of our ablation. So, show us the next. What we did then, we changed the transeptal sheath to the cryo sheath. We had a wire in the left superior vein, and we parked the cryo sheath in the left superior vein. And fluoro now. And now we are at this point. We are in the left superior vein. The balloon is in the vein, and the chief catheter is in the vein. And if you are happy, we are happy, and then we would start with the first ablation of the left superior vein. Okay, we start. Yeah. Yeah, I
Yes,
can hear
Professor
you.
Nawar.
Yeah. Yeah, good. Yeah, okay. Um, the chief catheter is a very important tool. Since the chief catheter was introduced by Medtronic, we had the opportunity to get live signals on the one hand. So we can isolate our veins as compared to a radio frequency ablation, and we can see live the isolation of the pulmonary veins. It is very important at the end of the day, when you want to see the live isolation, to pull back the achieve catheter as proximal as possible to the balloon. A very important thing. And on the other thing, which is very important, the achieve catheter gives you stability and gives you push and stability to maneuver the balloon within the ostium of the pulmonary veins. Okay. Yeah, I can hear you, yeah. Yeah, thank you. Very good question. Very good question. Thank you very much. I think it is very, very important to do selective pulmonary angiographies, because then it costs you 2 seconds of time if you know how to do. It is safe on the other hand, and you know where the ostium of the vein is. You never run into trouble to push the balloon too deep into the veins. Just imagine you have a left common os and you want to do the procedure. The balloon will be somewhere almost in the lung. Just imagine you have a huge right superior vein. The balloon will be inside in the vein and you go into higher risk to get a phrenic nerve palsy. This is something you want to avoid. If you know where the ostium is or how the specific individual anatomy of the veins are, you can decrease the risk of complications or harming the patient. And the other very important thing is you never oversee additional vein. There are patients with additional roof veins, just for example, or yeah. So these are the main things why we perform pulmonary vein angios. We do it in our institution in Hamburg since I don't know, since 15 years with the first cryoballoon generation already, and we never had a bad experience. No, I don't think so. I think we can show you the angios once again if you want. Can you show us the left superior vein? Go back. Go back. So this is the very inferior, and just keep in mind at CS 3-4 there's a horizontal branch. Now go to the other one. Go back one. So this is the same. The horizontal branch. It is the multipurpose is only directly, so it looks. So the horizontal branch looks like an additional vein. It's just more or less a short ostium of the left inferior vein. One goes a bit more anterior, the horizontal branch, and the other one goes a bit more posterior. And you can see here, even here you can see the inferior part of the left inferior vein. And now go one back. And this is the left superior. So with other words, if everything went smooth, we will isolate the left-sided veins with 2 freezes. One for the left superior, one for the left inferior with the mid branch and inferior branch. Branches, plural. cannot hear.
Go ahead.
Okay, we go ahead. Okay, so fluoro, please. Okay, inflate the balloon.
Philippe.
Inflate the balloon.
Wait a moment.
So the balloon is coming right now. You look, as you can see, the balloon is a bit. Can you see the balloon? Yeah, very good. It is a bit pre-shaped. That means the balloon is inside in the vein. It come out. Just go a bit inside with the achieve catheter for a second. Yeah. So now I can go out with the balloon. I push it a bit. Now come back with the achieve catheter just to get better signals. Very good. Okay. Now we go once to RAO 30. Click on 1.
I think we have PV signals.
Yeah. Most likely on the PV signals there's a spike.
On BV 3-4 we have
Fluoro,
PV
please.
signals as you.
Okay. Now we give some contrast and we can verify our position. So this looks like a beautiful occlusion. What does the audience mean? Should we freeze or not? Okay, we freeze. We'll see what happens. So start freeze.
Freeze now?
Yeah, freeze. We fluoro for you a bit longer.
4 minutes or 3 minutes?
180 seconds, please.
Okay.
So please have a look on the EP signals. It's already separating a bit and
Okay,
it's
it's gone now.
isolated. Automaticity, it disappeared. So maybe we can do one snapshot and we can show to the audience the isolation.
Deflated.
Do one
He will
snapshot, please.
deflate. He will deflate. Please.
Why? What happened? Why did you deflate?
Technical problem.
Oh, we had a technical problem, the balloon. We had to deflate the balloon. Okay. So no problem. We go to LAO 40 again. LAO 40 again. Click on 2, please. Fluoro ones, please. So what does Medtronic think? Can we try again or? So we need a couple of seconds. So I think we. I'm sorry?
Okay, doctor.
Yeah. This is a patient under deep sedation. Honestly, it is comfortable to do a mechanical ventilation, but it's not necessary. Some centers perform these procedures with patients who are awake. For a live case, we preferred the deep sedation. He's spontaneously breathing. And the main thing is we wanted to avoid the relaxation of the patient if you perform a mechanical ventilation, because if you want to ablate the septal veins, you have to pace the phrenic nerve. And when you start relaxing the patient, give relaxation, you won't see the movement of the diaphragm, and this could be a big problem. So that's why we have a spontaneous breathing patient.
So we are ready now to inflate.
Okay, I heard that we are ready right now. So we would start, no, we inflate the balloon, yeah?
Inflate.
Inflate, please. We go to RAO ones. RAO, click on 1.
Are you on?
The spike is back on.
Yes, my BV signals on 5-6.
Okay, click, yeah. Okay, now give some contrast ones.
Then, yeah. Okay, perfect.
Okay, I think the occlusion is good. We would start a new freeze and hopefully the machine works. So start freezing, please. Yeah. Can you see the electrograms? Yeah, I think so. How's the temperature right now? Maybe we can. Oh, we have again a technical problem here.
We need to replace cords on the cable.
Okay.
Okay.
Sorry for that. So we need to change a cable. So our main strategy. Okay, yeah, please. I just wanted to, yeah, please. Honestly, I don't care too much. Cryo is that easy, so it doesn't make too much difference. The only thing is, if you perform a cryo procedure in atrial fibrillation, the signals are sometimes not that good, which you get from the pulmonary veins, and so distinguishing which is spike, which is left atrial appendage far field or whatever is sometimes difficult. So what we do then, if we do it really in AFib and we do not see clearly that a spike disappeared, like in the initial try we did, we would check after we isolate all the veins, we would check all the veins again. But on the other hand, honestly, it doesn't make too much difference if you do it in RF or, I'm sorry, in sinus or in atrial fibrillation.
Ready now?
Okay, I heard from Medtronic, we go to LAO once again. LAO once again, click on 2. So hopefully it works. Because we had twice a wonderful occlusion. Fluoro, please. I pull the sheath back, as you see, because I don't want to inflate the balloon into the vein. So, inflate, please. Okay. The balloon is nicely round. Okay. We go to RAO once. Click on 1. Okay. Fluoro, please. Okay, and then give some contrast. I think we have a good occlusion, gives a bit more contrast, yeah? It's open, give again. Okay, fluoro? Yeah, it's perfect. Okay, so we start freezing.
Okay.
Please start freeze. Okay. So the balloon is still round, it's not deflated by itself. So this looks promising so far. Our contrast is still there. How's the temperature? I cannot see from here.
Minus 8, minus 11, minus 13.
It's not. Okay, it's okay. It's okay. Okay. I'm sorry? Okay.
You mean the target temperature, Professor Noor?
Oh, the vein.
Oh,
We had.
I don't hear you.
Minus 41 minute.
Okay, we have
We
a
are
2
now
to 1.
minus-
I'm sorry, we have a 2 to 1 conduction right now. The vein is not still completely isolated. Now it's isolated. This looks like an exit block with automaticity from the vein. It took a bit long, honestly, but this is sometimes the problem. When you start freezing a vein, deflate the balloon, start again, deflate, you create some edema. And in these cases, it can be sometimes a bit, take sometimes a bit longer. But however, we are happy. The vein is nicely isolated. It was faster within the first freeze, as you remember, most likely. Here it took, I think, we isolated after 50 seconds. So our dosing protocol says we give an additional 120 seconds. So we go for 170 seconds. 170, please.
170 moment.
Minus 44.
So the temperature is also okay. It's reasonable, minus 44. The vein looks still isolated. You can see the temperature also on the monitor. That's good. We can go to LAO once. LAO, click on 2, please. fluoro ones? Ah, yeah, good, okay, he's fluoring. Yeah.
We have ice cap on fluoroscopy.
Yeah, very nice. As Dr. Sanhoury said, you can see there a small ice cap on the distal portion or northern hemisphere of the balloon. There's a small ice cap. Okay, we finished our freeze after 170 seconds with minimum temperature of minus 44 degrees for the left superior vein. The vein is still isolated. I saw 1 second before, again, automaticity from the vein. Here you can see as well. Make a snapshot, please. Make a snapshot, show it, and go back. Here, here as well. Maybe you can see this is for us a proof of here again, automaticity from the left superior vein. So we are happy. We are now in the thawing phase of the left superior of the balloon, and afterwards we'll go to the left inferior vein. Maybe you can show us the left inferior vein once, the pulmonary angio. Back. Yeah, this is the left inferior vein, and what we want, the branch we want to target now is the left inferior, very inferior branch of the inferior vein, due to one reason. It is very nice to get somehow a hockey stick, and this is something we want to try right now, and this should work, and this is what we do and what we try right now. Okay, so the balloon is, did you stretch?
Yes.
Okay, so then fluoro, please.
Fluoro.
Okay, go further. We are in the, okay, so please have a look. It was a bit fast, but I think you saw it. We pulled the achieve catheter back into the balloon as well. I gave curve to the sheath. I went a bit, no, stay distal, please. Go more, go deeper, go deeper. Okay, now we are very, very deep inside, very nice. And now I go over with the balloon. Maybe come, yeah, okay, good. Okay, what we do now is we inflate the balloon once.
Inflate moment, please.
Okay, and we don't do too much. I come with the sheath to the balloon. I push. I don't push too much. Come back with the achieve catheter once.
Okay.
Come back, come back, come back, come back, come back, just to get a better alignment. Yeah, stay here maybe. Okay, and if you see this position, the cryo sheath and the CS catheter, it looks like a heart in a heart. In most of the cases, this will be a good occlusion. I don't want to promise too much, but we'll see. Maybe we can look in REO once. Click on one. Fluoro. The reason why we take the additional fluoro is we want to see how the alignment of the sheath is. Because just imagine the balloon goes into one direction, the sheath into the other direction, you will lose the whole force to the pulmonary vein. But this looks pretty aligned, so I think we can just try to give some contrast. Very strong. Oh, this looks like a good occlusion.
Yeah.
What do you think? We can start, or? Okay, it's okay. Okay, so then. Okay, then we start.
Okay.
We start freezing. Fluoro, please, for the audience. Fluoro. So the contrast still stays there. Oh, it's getting longer.
Yes.
Please have a look on the PV signals, and it's already almost isolated, 2-to-1 conduction, and the vein is isolated after 22 seconds. So according to our dosing protocol, we would say after 20 seconds, additional 120 seconds, so we go for 140 seconds for the left inferior vein. Please change it to 140.
140?
140.
Another important point here, we have one-to-one relation between temperature and time.
Yes.
We have a drop in temperature in one-to-one fashion. With the
Yes.
time.
Yes. Yes.
This is very important.
It's very nice. Yeah. The target temperature. I think at the end of the day, yeah, I think yeah, the target temperature is not the important thing. I think we stop our freeze at minus 60 degree if we reach it. But to say we want a target temperature of minus 50 or minus 45 shouldn't be the correct way. It's a surrogate parameter. It's not exactly measured on the one hand. It is more important. If you just have a look on the cryo console once, we have a can you go with the camera to the cryo console? Where's the cameraman? Oh, man. Okay, to have a continuous drop in temperature. Temperature degree for degree. Yeah, as you can see, minus 45, 46, it goes slow down, slow down. Even if we have minus 42 or minus 41, and if it is a continuous drop, this is much more important than the maximum temperature. Because if you reach minus 50 and in the next second it is minus 41, it shows you that there's somewhere a leakage, that the contrast, that you will never get good transmural lesions. If it goes continuously down, everything is fine.
Okay. 140.
Okay, so we isolate the vein. We have,
Yes.
okay, we should stop it. Okay, so we isolate the vein after 140 seconds, and yeah, we are happy. We have to do this.
No.
We know at the end of the we won't. We saw at the end of the day the live isolation, and if the vein is live isolated, we don't do any more pacing maneuvers for entrance block, pacing from the vein or from the CS catheter. If you want, we can do that. But if you see the live isolation and if you see that everything is fine, the vein is isolated, it's okay. But if you want, we can pace once. Okay, then let's. We have to. We go to LAO once. LAO 40. Okay. No, in this case we didn't do any manipulation. Sometimes we do manipulations, of course, but in this case, if the temperature is not good enough, or if you see there's inferior leakage, we do a pull-down maneuver. Here we didn't do. In this case, because it was not necessary. We had a wonderful occlusion, so I just we freeze in the left inferior vein, and we had a wonderful occlusion, and everything was stable at that side. So we can fluoro once. Wait. Stay outside. Okay, so we have an atrial far field. Maybe we can paste once from CS 910, reduce output a bit, just to show the audience if the atrial far field, if there's a separation in the atrial far field or not. So we pace, and as you can see, we capture on. No, we don't capture. No. Now we can see. You cannot see. Can you show them the intracardiac ECG, please? Okay, now you can see. We pace from the. Please put it again on 100 millimeter per second. This is easier for the audience to see. So as you can see, there's a spike, the pacing artifact. Afterwards, there's our atrial far field which does not separate, so there's no spike anymore. If you want, we can pace even once from the lasso. From the achieve catheter. Then pace once from the achieve. We do not capture. We do not capture. So stop pacing. Okay, if you don't mind, we go to the right inferior vein. Okay, so then I'm sorry.
A question from the panel.
We do. Yeah. Okay, so then let's go to REO 30, please. Yes.
Yes. We start with the right inferior.
Yes, we start with the right inferior vein. Can you show us the angio once again of the right inferior vein for the audience? Go back, back, back. One more back, one more. So, this is a vein which is not too small. So what we do right now is, we take the fluoro, please. We take the CS catheter off, put it in the high right atrium. Can you pace from the distal, pace from the distal CS once? Yeah,
CS
I'm sorry. Yeah. Yes. Yeah. Yeah, I can tell you, we're doing this clockwise movement. That means from counterclockwise movement from left superior, left inferior, right superior since a couple of years, due to one reason. If you have a phrenic nerve palsy, the risk of getting a phrenic nerve palsy is much more higher in the right superior than in the right inferior vein. So if you have a phrenic nerve palsy, you have at least 3 out of 4 veins isolated, yeah, and this is the only reason why we do first the right inferior vein, just only for the patient. We changed our protocol a couple of years ago. Okay, good. So then, fluoro, please. So what I do now is I pull back the, yeah? Yeah. We normally do only 2 punctures. Yeah. Yeah, very good question. Normally we do only 2 punctures. We just had 1 additional puncture because this is a live case. You never know if something happens. But in a normal case, in a routine, we would have only 2 venous punctures for a normal cryo case. Okay. Good. Fluoro, please. Yeah. Yeah, we do. We try in a second. I just wanted to go over with my sheet. What I did now, I pulled out of the left inferior vein. I opened a bit, pulled a bit back the sheath, opened a bit, pulled it back, just to be sure not to perforate the roof. I do not open complete. I pull back, open, pull back, open, and then I do a clockwise movement towards the posterior wall because I have much more space at the stop. And here's the right inferior vein. Now come out with a Achieve catheter. Can you move the table a bit into this direction?
كده شوية.
Just move the table. A bit more. A bit more. Thank you. Perfect. Now come out with the achieve catheter. You have not too much. A bit back. Okay, stay there. Okay, please pace the CS12 for a second. With maximum output. So getting the phrenic nerve is sometimes more difficult than everything else in a cryo procedure. Can take longer than everything else. Is it maximum output?
Maximum output.
So we don't
Go
have.
higher up, I think.
I cannot hear. I didn't hear the question.
I didn't hear.
What?
Dr. Ghalia, repeat the question, please.
Can you make the microphone
Yes,
louder?
we
I
paste from
cannot hear.
CS1
Yeah.
to the distance, yes.
No, we're
No,
pasting
pacing from the coronary sinus.
from the CS12 catheter.
Oh,
Oh, you're
Dr.
right.
Mu'taz, paste from-
Please paste from the correct catheter. Thank you very much. And I was wondering. Thank you very much. Very good.
CS1 to.
Okay, now he's pacing. So we will never find a capture. Okay, Floro, please.
Fluoro. Now.
Here. Now we have. Here we have a good capture. We are pacing now. Yeah,
Dr.
we are
Mu'taz,
pacing.
reduce the rate. Reduce the rate.
Okay, stop
The rate
pacing
of
for a
pacing.
second.
Stop.
Stop pacing. What? I'm sorry. Yeah.
Reduce the rate of pacing. The rate
Oh,
of pacing.
okay, thank you.
40.
Okay, when you finish the description, we would continue at this point. Mohamed, please stay here. Mohamed Sanhoury,
Reduce the pacing, give it to 40.
we continue. Okay, so we would continue right now. Please, Flora once. We come out with the balloon.
Okay.
So one of the nightmares in cryoballoon ablation and in ablating the right inferior vein is when you lose the sheath into the right atrium, and if there's not enough space. We will see how it works here. So inflate the balloon, please. Okay, can we go to LAO once? I just want to see the alignment, especially for the audience. LAO 40,
LAO.
click on 2, please. Click on LAO 40, please. Click again. So as you see, the sheath was before like this. What I do now is I do a counterclockwise movement to get a better alignment to the curve of the catheter. We just give some contrast to get a rough idea where we are. Give some contrast. Oh, and we have good.
Occlusion.
We have a good occlusion. I think we accept it and go for a freeze. Start ablating, please.
Okay.
Go to REO once. Go to REO. Click on 1. So after 20 seconds, after 20 seconds. Oh, wait. Go to 180 seconds, please.
180?
Yeah, 180. So when at the time when we reach -20, we start pacing. It's right now. Start pacing, please. Pace. Fluoro.
Okay.
Okay, pace a bit slower, please. This is too fast. Fluoro, please. Our temperature is not fantastic, honestly. So what I do right now is I try, because we had a wonderful occlusion, and it's something like a plateau phase right now, so I do a pull-down maneuver. Yeah, and as you can see, we got a small temperature drop. Pace. As you remember, the plateau phase was at minus 32 degrees. I did a pull-down maneuver, and now we are at minus 39. So we have a delta of temperature of minus 7 degrees already. So the pull-down maneuver helped a lot. Unfortunately, in this vein, we do not have any nice signals, but due to the curve of the vein, I was pretty sure that we will lose the good occlusion if we pull back the achieved catheter too much, because the puncture site was a bit too, transeptal puncture site was a bit too anterior, honestly, and so the distance is not too short. So right now we are at minus 44, minus 45 degree. Temperature is reasonable, is good. It's a continuous drop of temperature, and we will do 180 seconds. 180 seconds is our standard if we do not see a live isolation of the vein. We do not do any more bonus freezes or additional freezes. We just do one application with 180 seconds. And once again, we have some, yeah?
Okay.
5 minutes left for?
Yes, just 5 minutes.
5 minutes left for the rest of the procedure? Okay, good. Oh, I see. Okay, okay. So if we hurry up, we can see we have 2 more seconds for the right inferior vein. Stop pacing, please. 5 minutes should be enough. Okay, so we will, the balloon is deflated right now. The freeze is over. We just wait for, we have to stretch the balloon once, check the vein, and go for the right superior vein in a couple of seconds. So we can stretch the balloon. Fluoro, please. We hurry up. Fluoro. Okay, I pull back the balloon.
Can check the ostium was achieved.
Yeah, okay, stay here.
Okay.
Yeah, maybe there's still small spike. I think we have to give one more freeze. Just go a bit more inside. And now pull back, just to be sure. Pull back again.
Fluoro.
Can you make a snapshot? I think it's honestly the same timing as the SVC catheter, but if there's, this must be a spike. If there's such a big signal in the right inferior vein, this is a spike. So I would suggest we do one more freeze and try to do a live isolation. Fluoro, go deep in. Yeah, very good. Okay. Inflate the balloon once.
Inflate.
Yeah, inflate. Now try to come back with the achieved catheter a bit. Stay here for a second. Okay, now we go to LAO once, just to get a better signal for the audience. LAO, please. LAO, click on 2. Fluoro. Give some contrast. Occlusion is okay. We can pull back the achieved catheter a bit, just to get some signals for you. Oh, was it automaticity in the vein? No. Pull back a bit.
No.
Unfortunately, there are no signals. Okay, pull back more. We want to have live signals for you. We want to see a live isolation. Pull back. Pull back. Oh, now we have something, but we lost our branch. We give one more shot of contrast. Maybe we lost our good position right now.
No, outside 3.
Okay,
Outside the
so deflate the balloon once.
Deflate.
Go to REO, please. Go to REO, please. So the balloon jumped out. We pulled the achieved catheter. Okay. So I think we have to accept that we won't get a nice live signal. Sometimes it's a problem to get a nice signal, but however, we deflate again and we try our best now again. Inflate, please. Okay, give some contrast. We have a very good occlusion here. We start freezing.
Freeze.
180.
180 seconds. Unfortunately, no signals. We tried our best at this position, but sometimes we have to accept it.
Be ready.
So, and again, at minus 20 degree, we will start pacing. We are at minus 17, minus 19. Please pace.
No.
And we have capture. I can feel it from my left hand, the movement of the belly. When we fluoro once, we can see the movement of the diaphragm. Please fluoro once. You'll see a nice movement, so we have a good capture. We won't run into any trouble. Temperature drop is okay. We will do a pull down maneuver in some seconds. Yes, yes. A pull down maneuver is when you have the feeling that you have an inferior leakage. With other words, that the balloon occludes the proximal portion or the superior portion of the PV ostium, but not the inferior portion. And what we do now is, fluoro please. Please look on the fluoro. I pull down sheath and balloon. Just look. See, I pulled everything down. And now we can see if there's some change in temperature. Yeah, temperature goes a bit down, minus 34 or so, yeah, very slowly, but. Minus 35, yeah. 2 minutes are left, okay. Are there any questions from the audience so far? Was there a question? No.
No. Should we reverse heparin at the end of the procedure?
Oh, I see, okay. We do normally, yes. If the ACT at the end of the procedure is still high, maybe over 400, we would reverse heparin with protamine. But if the ACT is at the end of the procedure, so we do every 30 minutes, ACT. If the ACT is somewhere around 250, 260, we won't reverse. But if it is more than 300, 350, we would reverse heparin.
We stopped. We are sewing it now.
I cannot hear.
Stop phrenic pacing. Stop pacing.
Do you understand the question?
No.
This was,
No,
I'm sorry,
repeat the question,
my
please.
microphone is almost broken. Can you just repeat the question? I just try to listen.
During the procedure, you mean?
No, you're talking about peri-procedural before and after. We do with continuous anticoagulation. If the patient is on warfarin, we would continue warfarin without any problems. We have enough data that this is a safe approach under continuous anticoagulation. Even for the so-called NOACs or DOACs, the new anticoagulation medication, we have right now more and more data that it is safe. We are a bit conservative in Hamburg in our lab. We just stop the last medication of a NOAC and give it, but immediately 6 hours after procedure again. So there's only a short interruption, but I think we will change it in the near future. And we will do it under continuous anticoagulation because we have more and more data that this is safe. And we have for dabigatran, we have an antidote. The antidote for the other 10A inhibitors got the FDA got the permission from the FDA, so it will be available in the US and Europe end of the year. So I think it is feasible, reasonable to do. We do always, before every catheter ablation, RF or cryo, if it is a PVI, atrial fibrillation with atrial fibrillation, we always do 1 TE before the procedure, the day before or in the morning before. It was a pleasure. Yeah, thank you very much.
Thank
We're
you for
happy
all and
for the procedure.
Welcome, cardiologist.
Welcome.